Medicine Society of Nepal. It's my pleasure to welcome you to another episode of Himali Sambad. It is our fourth episode. This is a platform where we bring together clinicians, researchers, and we all mountain lovers to share experiences from the unique world of mountain medicine that we all love, cherish, and will love to work and contribute in future. Today's session is interesting. It is titled "Where the Air Runs Thin: A Conversation on Everest Air." It's a topic that will take us to extraordinary healthcare settings on our highest healthcare setting probably, and this is the Everest emergency room. Practicing medicine at such an altitude above 5,000 meter is unlike any other condition that you work. I understand the ER in Nepal is chaotic, but I believe the ER at such altitudes has its own challenges. And this evening, we have the amazing privilege of hearing firsthand from two physicians who have lived that experiences and has been guiding new generation of mountain lover physicians to live that experience as well. They have worked on the front line of high altitude medicine, and they have been caring for the climber, trekker guide, local communities, and also training as juniors while at the University of the Himalayas. So I would like to welcome our speaker, Dr. Subarna Adhikari. He is an attending emergency medicine physician in the University of Maryland Shore Regional Health System on the eastern shore of Maryland. He has a background in orthopedic contributions in Mountain Medicine of Nepal, in Mountain Medicine Society of Nepal, uh, and has served as course manager for diploma in mountain medicine in Nepal since 2011. He has also worked as executive committee member of our Mountain Medicine Society of Nepal and collaboration for emergency care Nepal. And he has special interest in learning, in online learning platform and health research, and has supported the development and maintenance of online learning resources for international courses in Nepal. So welcome, Dr. Subhan Adhikari.
Thank you very much.
Uh, assistant and he also
Sachet, can I stop you for a second?
as an
Sorry, Sachet, we can, at least on my end, you're breaking up. I don't know if that's happening with other people also.
Yes, Suvarnada, it looks Sachet end is not does not have a good internet. I'm hearing you well, but not Sachet.
Yeah, so I can also see that Sachet's audio and video both are lagging. Sachet, I think you should speak slowly and try again. Let's try introducing Sanjeeb again. Sorry, because I didn't hear anything you said about Sanjeeb. And sounds like everybody else had the same problem.
Okay, my internet. Hello, am I audible now?
Yeah,
I
yeah.
have
So
changed
let's
the internet. I
try.
hope this one works.
Yeah, we can hear you better now. Let's try introducing Sanjeev again because we did not hear anything about Sanjeev. And let's try to go a little slower this time.
Sure. Now, let me introduce to our second speaker, Dr. Sanjeeb Sudarshan Bhandari, who currently serves as Assistant Medical Director at the Himalayan Rescue Association Nepal and Co-Medical Director at Everest ER. He is also an attending physician at Western Maryland Health System in the United States. What happened to my internet again? So,
We can hear you now. Yeah, we can hear you. Yeah.
So he's also an attending physician at Western Maryland Health System in the United States and has worked as an expedition doctor since 2015. And he has special interest for Everest ER, and he has volunteered at Everest ER in multiple seasons in 2014, 17, and 2022. And as a former executive member and chief editor of the Mountain Medicine Society of Nepal, Sudarshan Dai is someone many of us in MMSN look up to. We look up to you guys, and we hope most of us in our medical school and throughout our journey, we look up to you guys and believe that we will also go to Everest ER, go to high altitude sittings, and practice this wonderful form of medicine. Now, I would like to for you guys to take over the session.
Um, Thank you. I can go first. Thank you, Sachet, and thanks Mountain Medicine Society of Nepal for organizing this. And this is our fourth episode, looks like, of Himali Sambad. And thanks for carrying on with the conversation regarding high altitude and what our experiences are and what we can do going forward. This is very interesting. And what I would like to say up front is I am thankful not just to the this platform, but also like to everyone who is going and serving at high altitude. All of the work that we do through Mountain Medicine Society of Nepal mostly is voluntary work, and there has to be a lot of passion and interest for us to be able to do that. It's not just Everest ER. We have an AIDS camp run by the Himalayan Rescue Association at Periche, which is also in the Everest region, and also in Manang. And then there are so many other stations where our members and Nepali physicians and medical students go and serve, and that's really impressive. And also, just not to forget Gosaikanda. So this has been ongoing for years, and it has expanded over the years. So again, like you already said, I went to the Everest ER just once. Sanjeeb went there 3 times. There are so many others who have gone multiple times as well. I just happen to be the face of the conversation alongside Sanjeeb, and it's my pleasure to be here. But I want to acknowledge that Subhash is also on the conversation. We went together, Dr. Subhash Dawadi, and there are so many others who have been there. Dr. Ashish Loni has been there multiple times. Pranav Perera has been there multiple times, and some of you who are present here, I believe, have also been there in recent years. And like Sachet said, many of us want to go there again and again. So that's the kind of enthusiasm we like. So working in the Everest ER is different from working in any healthcare setting, and that's what we'll try to unravel throughout today's talk. And Sanjeev, if you want to just introduce and I'll say a few words. I just want to say one correction on behalf of Sanjeev. He has recently started working in Washington. He just moved from Maryland to Washington. But this just happened last month, so we're still catching up. So let's hear a few words from Sanjeev, and then we can proceed.
Yeah, thank you, Sachet, for the introduction. Yeah, we are all passionate about mountains, and I think we'll get to talk to other people who are attendees who will be going to Everest ER, Feriche, Manang to work, and I hope this presentation will be helpful to them to know more about what MMSN does in coordination with Himalayan Rescue Association.
So we will try to unravel the logistics, the idea behind Everest ER, and the kind of work that we do there. Let's go to the first part of the first slide. This is how we ascend to the Everest Base Camp, and we start in Kathmandu. Obviously, we all know it is at 1,400 meters, and we take a flight to Lukla. I'll show you pictures in a moment, but this is considered one of the most dangerous airports in the entire world. A lot of accidents, mostly in flights over there, but that's our only airport in that region that is closest to the Everest Base Camp Trail. And that's where we stay the first night. And the structure that you see is a gradual ascent. And this is what we have to do when we're ascending to a place that is as high as 5,364 meters, because we all know altitude illnesses can be prevented if we had graduated ascent. And the idea is 300 to 500 meters of ascent every night. Where you're sleeping is what matters. Unfortunately, we also have to plan the ascent based on what is available in the trail. And there are some villages scattered throughout the trail going up to the Everest Base Camp. And we have to plan to stay in those villages. We can't just say, okay, I'm going to stay at exactly 300 meters or 500 meters tonight because that's what the guidelines dictate. We also have to plan our trip based on what is available. Once we land in Lukla, human beings like us, and there's a group of there's a group of trekkers who just go to the base camp and return. They join a CME trip with the Wilderness Medical Society. So there's like a big group of 25 people going up together. So we all hike up. Our goods and the equipment that goes to the Everest Base Camp, a lot of it is carried by these animals. And some of these are yaks, but like some of these are also crosses between yaks and local cows called jokkyos, kind of like mules, but these are stronger and sturdier, and they can carry heavy loads for long distances across multiple days. This is then I will show you pictures of these places in between. Lukla, we go to Fakting because it happens to be a little bit lower, but it happens to be along the trail. And then spend 3 nights in Namche Bazaar, keep ascending. We spend 3 more nights in Perite because the ascent from there is pretty steep and it's kind of dangerous. People get sick over this ascent from Perite Gorakhsep. We don't really stay in Lobuche. And then the last push to the base camp. So some of you have been to the HRA 8 post down here, the center at the bottom. This is the picture of the HRA 8 post in Periche. But again, left top, Lukla Airport, left bottom, Lukla Village. And then this is not a very representative picture of Namche Bazaar, but that's what it's kind of like, very busy and then kind of spread throughout the hill. Tengboche along the way, and bottom right is an interesting place in Lobuche. It is on the research pyramid that it used to be a research facility, and but from what I hear, the research work has been kind of dwindling, and then it's more of a resort or a hotel at this point. But this is also one of the places we got to visit during our hikes, and it was pretty interesting. So you get to see a lot of places along the route. Also, going to the next slide, you get to see the celebrated wonderful mountains along your route as well. And Sanjeeb, can you care to comment on where we are, what we're looking at, and then why this is important?
So we are looking at Mount Amadavalam from the other side. We've only seen it from the southern side. So you know, everyone recognizes Mount Amadavalam from the southern side, how it looks with a bigger peak and with a smaller peak on the side. This is from the west side, so from towards Feriche. If you look at Amadavalam from Feriche or from the hill above Feriche, this is how it looks. And this is a very vital milestone on the trek or route trekking to Everest Base Camp.
So a lot of parties going towards the Everest Base Camp. We will split like around this place, and then many of them will go towards Mount Amadavalam, which is also one of the most climbed peaks in that area as well. And it has a lot of, I mean, it's very beautiful. It has a lot of religious significance, cultural significance in the region. And then also in terms of like milestones, like Sanjeeb said, once you reach there, you have a sense that, okay, we're getting close to the base camp. Close to our destination. And again, this is also very important. Gorakhsep is the final settlement in the area. And once you push through from Gorakhsep, there's no human settlements beyond that. Again, also important because there's a hill next to Gorakhsep or like a landmark, geographical landmark called Kalapathar. And that's where you get one of the best views of Mount Everest really from. Because you're so close to Mount Everest, when you're in the area, you can't really see the peak itself because it is hidden, even though it's the highest peak, it is hidden by other smaller mountains. And you also really cannot see the peak of Everest from the base camp. But from Kalapathar is where you can really see the first good view of Mount Everest, and also like one of the most wonderful views. On the left, you can see the black ridge at which it looks on the left, kind of like in the back. That's Mount Everest. And in front of it is the West Combe, which is the West Shoulder, which is what you can see from the base camp. Hidden in the back is Lhotse, and then on your right is Nupse, and along the center is the Khumbu Glacier. which is also one of the most important places. So not only do you experience mountain medicine, but you get to experience part of mountaineering as well. You get to kind of like vicariously lead through the geography, through the people, and then kind of learn what happens in that area. This is the view once you reach the base camp. A lot of settlement has already started even before you have set up a tent for Everest Base Camp. And these people, some of them are already getting sick. Some of them need medical care as soon as you arrive. So your job starts the moment you get there. We're going to share that in a moment, but one of the reports from Everest Base Camp over the years, it said that, okay, people were ready and lined up to be seen as soon as we reached the base camp. We hadn't even set up tent yet. So top left, one also important landmark. I'm really excited because these are beautiful views. These pictures don't even do justice about the feeling and the kind of experience that you get once you get there. But Mount Pumori is on your west, north. Like all of these are on the north, but northwest you can see Mount Pumori, which is a majestic big mountain, and also really beautiful if you look at it. And then on your east is what you see, or what I showed earlier, Everest and Nuptse, Lhotse, and the Khumbu Glacier, obviously northeast. And this is me first arriving at the base camp, really happy and excited, and also very tired and exhausted. So Sanjeeb, that's you, right? That's your team?
Yeah.
Do you care to comment? Yeah. So do you care to comment on this slide? What's the requirements? How do you even get to go to the base camp as a base camp physician? What kind of experiences? And for me, it was an interview with Dr. Luan Spear, but what's the kind of deal right now?
So right now, we conduct interview. I'll be there. Dr. Luan Freer will be there, and Gobidai will be there, and three of us conduct interview for the people who are going to Everest Base Camp, especially the ones from outside of Nepal. Subhash still does interview Nepalese candidates, and we try to confirm that as well. And yeah, we want someone who has worked at it's a harsh environment to work at. So we want someone who has already worked at the high altitude and who has a track record of working there well and adapting to the high altitude well. Saying that, we also conduct diploma in mountain medicine through MMSN. So people who have done diploma, they have to spend at least a couple of weeks at high altitude and at least a week at the glacier. So if they have done that, that's one of the experience that they have, and also have the skill set that's required to work at the high altitude. On top of that, if they've worked at Gosaikunda or Manang or Feriche, that's a plus point. And yeah, we do rigorous vetting. We conduct interviews and try to select the best candidate possible to work at the Everest Base Camp.
And is a general idea that there will be at least 2 Nepalese physicians and 1 international physician? That's the kind of goal right now. Is that correct?
That is still the goal, but last year we had difficulty finding a second Nepali candidate. So from this year or this coming year onward, we are taking 2 foreign candidates because it seems like it's difficult to find 2 Nepali candidates at the same time to work at Everest Base Camp, which is not the ideal situation, but we need 3 doctors to work at Everest Base Camp to make sure that everyone is not overworked. So from this upcoming year and maybe 2 more years, we will be taking 3 foreign candidates and only 1 Nepali candidate, since we are having difficulty getting a Nepali candidates.
So the recruitment goal is to be able to take 2 Nepali physicians if possible, but we're keeping our recruitment open for 2 foreign candidates because we're not getting enough Nepali candidates, correct?
That is correct.
And just to clarify, Dr. Luan Freer was the founding director of the Everest ER, which is what we're talking about today. And Subhash Dawari, that Sanjeeb mentioned, Dr. Subhash Dawari is in the HRA board. And I believe he's also in the current talk. I don't know if Mr. Gobi Basyal, who Sanjeeb just mentioned, I don't know if he's in the among the participants today, but we did invite him, and hopefully he can be here sooner or later. Um, and he can give us more insight on how the logistics work. And at this in the picture next to Dr. Luan Freer, between Sanjeeb and Dr. Luan Freer, is Nimadai. What's his middle name?
Lakpadai.
Sorry, Lakpa
Lakpadai, and that is not Dr. Luan Freer. That's Erin, who I worked with
that's
in
right.
2022.
I'm sorry. Yeah, that's not Luan. Okay. So that is your team. So that's Aaron, and then that's Lakpadai, and that's you, and then this is Amro
Samriddhi.
Samriddhi. Okay. Yeah. Okay. Thank you. um, So once you arrive at the base camp, it's just so just to clarify, the Everest base camp itself, where we set up camp, it's a moving glacier. It has been moving over years. The only good thing is it moves really slowly. But once you set up tent at a certain spot in the base camp, it's not uncommon for the glacier to move over that same season, like because you're there for 2 months. Rock and ice and things will start moving, and then your tent kind of like tilts over, and then you have to set up camp again. So that's not uncommon. So you have to find a spot where we can set up this huge tent over a platform, and it has to be as sturdy as possible, but then the maintenance is ongoing even once you set up camp. So in order to be able to find an area where you can set up this camp, which is usually like a um, 30 feet by 10 feet platform that you need. Again, it's hard to find that area which is flat enough, 30 feet across 10 feet. And you'll see in the next picture that it takes a lot of manual work to actually be able to set up that platform. Not only do you need a platform for the Everest base camp, Everest ER tent, but you also need a platform adjacent to it for helipads, at least 1 or 2 helipads that you are not too far from the Everest ER clinic. But again, everything has to be based on geography, based on appropriateness, based on what weather conditions to allow. So we are not equipped to have all of that kind of information. We have once we have been there for so many times, we can have more insight into it. But we're not technical experts for that. That's why we need people like Lakpadai, who have been there over the years since the starting of the base camp clinic. They have been there every season, and he's also a rescue expert. So he has a lot of input and a lot of importance in what we do. But without him, we would probably not be able to run. So that's the kind of support we need from our ancillary team. But again, you go with an expedition team because you cannot survive on your own. So the expedition team and the experienced Sherpas, they will also help in this logistics and kind of like technical ideas on how to set up camp and where to work and things like that. And again, you'd imagine this tent, everything's cold, but you have to be in this tent for so many hours throughout the day. So the general idea is you open at 9 a.m. and then you keep running until 5 or 5:30 p.m. So we're kind of running an outpatient clinic alongside just being an emergency. So we're the only healthcare body there. So you want to be able to have electricity there. You want to be able to kind of keep the tent as warm as possible. So space heaters have been carried by the job queues that we talked about. But again, we're also carrying some solar panel equipment, and these only work when the area is sunny, and that's unpredictable. That's okay whenever we can get it. You cannot control that. So we do have battery backup in there, but then again, it doesn't work all the time. So in terms of communication, we have our mobile phone network is so good right now that we can get a good mobile phone access over there, but it's very patchy again. At best, you can probably usually get better connections at overnight, but again, if there's a wind, if there's weather coming in, it is unpredictable. So this is how it was set up when we went. So we're slowly flattening the platform. These are wooden frames that were used to set up the platform. And again, just like trying to set up tent, we did extend our helping hands, and then we had a huge collection of medicines that we needed sorted out. But luckily, we did have good medicine cabinets where we could sort out equipment and things like that. And on the top right, you can see our tents. This is where we stayed in for 2.5 months, and these were really wonderful. These were like spacious, again, really comfortable, and we had a lot of stuff in there too. Inside the Everest ER tent, we have essential life support equipment, pulse oximetry, glucometers, cardiac monitors, and 12-lead ECGs, and that directly connect to the laptops. But in terms of advanced imaging, we don't really have any. It is just point-of-care ultrasound, which is as good as it gets, but it's also like very versatile because you can use it for a lot of things. And we can do splinting, and we can probably do suturing, but a lot of things have to be transferred out. There was a dental extraction that was done at some point, but that's not usually our goal. I mean, if we have to, we will do it. This is the top left, just name hidden for sake of hiding personally sensitive information, but also these are the kind of things that we see there. That's the kind of patient information log that we have. Again, wonderful view from the tent that we stayed in, and a lot of variety of food. You can have pizzas, you can have chicken chow mein and everything like that, and you can have all sorts of food. But my favorite was the the Sherpa stew. I wouldn't eat this food they prepared for us. I would just go and share food with the cooks and the workers, and that was the most amazing meal I ever had. This is Brenton Sistermans, my colleague who is from Australia, who was with us in the season, and then Dr. Subash Sabadi, bottom right, examining a patient. So let's go into overall logistics, financial, and operational model. Again, I want to call out if Mr. Gobi Basiali sir, Gobi sir, if you're here, would you care to comment? But I cannot see him here, so he's not. So again, Sanjeeb, this is on you. Could you talk about how we manage the logistics and how payments are handled, like who has to pay and how much, and how this is all done?
So HRA is Himalayan Rescue Association is a non-profit organization that's set up more than 50 years ago. How it works is it works on donations, and it does not take donations from any political organizations. Since COVID, it has also started getting some donation from the Nepal Tourism Board. So since then, it's been treating all the Nepali visitors to the base camp, including all the support staffs, for free. The other fee structure is we charge $100 for the whole season from any foreign climbers that wants to get our services, and that usually is through their expedition company. So when the expedition company has all of their registered climbers, they usually go to HRA office in Kathmandu and pay $100 per climber. If they have 10 climbers, they pay $100 per climber, so $1,000. And these climbers will get unlimited number of consultations from our doctors for the season, like from the beginning of April to the end of May until the season concludes. Some expedition companies do not register in Kathmandu, and they also have an option of doing the same at the base camp. And if the expedition company does not do that for their whole climbers, even an individual climber from the expedition company that does not enroll with us can come, pay $100, and get an unlimited number of consultations from us. We do not charge for medicine to any Nepali visitors or patients who come see us, but we will charge specific amount to foreigners for medications, depending on what the medication is. If it is paracetamol or ibuprofen, we charge like, I think, $5 or something like that. If it's something more specific, like blood pressure medications or something for hip, haste, dexamethasone, nifedipine, we charge like $20. And if it's like some have Kumbu cough and need inhalers, or has like asthma, COPD and need inhalers, we give them inhalers and we charge like $15 or something like that for the whole thing, which is a lot cheaper compared to what they have to pay at their home country. So that's how the financial flow works into the Himalayan Rescue Association. And also HRA buys a whole lot of medications and supplies and sends them to Everest ER. And also HRA pays for all 3 doctors and a rescue specialist, like Pradai, their accommodation and food to the expedition company who we are attached to. So we stay with one expedition company, and that expedition company takes care of our lodging, like our tent and everything, plus our food. Like they provide our morning coffee, lunch, dinner, khaja, and frequent like teas and coffees. So Himalayan Rescue Association pays to that expedition company for our logistics as well. And as I said, the care access is heavily subsidized to Nepali visitors, and we take some, we charge foreign climbers some amount of money. It used to be just like a cash payment in the past, but since 2018, 2019, we also have a POS payment method, so people can also pay through their cards. And that directly goes to Himalayan Rescue Association account. So that's how we run our financial machine.
So again, Sanjay, because you've been there so many times and you've seen the trains change, just comment on this slide that we have in front of us, how the patient demographics have changed over the years. Mostly Nepalese climber workers at this time.
So how it used to work was a company has to register all their climbers to HRA by paying $100. And when they do that, all of their support staffs will get free care, but they still had to pay for medicine. But since 2021, we started getting some donations from Nepal Tourism Board, which works under tourism ministry. So it's a governmental money. So we said that we'll provide care to all Nepalese for free, irrespective of if their teams will register or not. And then we started doing that. After that, our Nepalese visitors, it's easier for Nepali support staffs, like kitchen staffs, cooks, not just climbers and guides, but all the staffs that works for the companies who are Nepali and who are at the base camp doing the real work can easily come and see us when it's needed. So I think that's one of the reasons we have increased visits from Nepali workers in last few years compared to like before when we started making visits free for Nepali workers if you are not registered. So I think that's one of the reasons. Plus, on top of that, the volume itself of climbing Everest has increased, and the volume of Nepali climbers has also increased. That's another contributing factor which increased number of Nepali people visiting our clinic compared to the foreign climbers. And it used to be like all the mountain guides who will guide the climbers up the mountain. They were mostly like non-Nepali mountain guides or like certified mountain guides. But for last 10 years, we also have Nepali Mountain Guide Association, and we have all certified Nepali mountain guides. And that number has increased from 40 in 2017 to I think it's like almost 300 now. So that also makes a huge difference on who is guiding who up the mountain. So right now, the majority of expedition companies are run by Nepali, and majority of the guides guiding climbers up the slopes of Mount Everest are also Nepali. So that increase in number has also contributed to increase in Nepali people or Nepali visitors to Everest ER clinic, if that makes sense.
Yeah, and I think that's now very illustrative and kind of explains why we see these different numbers. I was just looking at the brief season report from 2025. I didn't get a detailed one for 2025, but that also says that we had almost 85% Nepali clients, and also the total number was around 700 something, and among them 85% were Nepalese. Also, at the bottom of the slide, I have two comments. There are two different kinds of clients that we see. I mean, obviously, we see workers and Sherpa guides. Those are the Nepali population. But then we also see seasoned climbers and the seasonal trekker. Sanjeeb, would you explain us the difference between these two clients and what to expect? Why are they really different?
So seasoned climbers, their job is to like climb, or they have climbed mountains in the past, so they know what are the risks that climbing the mountain brings to them. So they know about altitude related illnesses, they know about traumatic injuries, they know about like all the blisters and nail injuries that comes with the mountaineering. So they know a lot about the illnesses. So they take precautions to prevent those things. And those are the experienced people who have already had some kind of illnesses, or they have read about it, or they know a lot about it. But they're like these seasonal trekkers who, I think I was like that when I was in second year of med school, when me, Subhas, and our other friend Susan went to Gosai Kunda, no, first year, from first year field. We were just there with a hoodie, a basic like tennis shoes, and whatever bag we had. And that's how most of the seasonal trekkers are. Sometimes they just come up in their Converse shoes, and like not even like basic equipment required to be at that altitude. And those are the people who get sick fast, and they don't know how the sickness looks, mountain related illnesses look. And those are the people who have tendency of getting really sick. And also we have heard a lot of incidents about deaths at like while going to Mount Tilicho Lake and things like that. So these are the people, these are the seasonal climbers who have very high tendency of getting sick and getting ill, who have no knowledge about altitude related illnesses, no knowledge about any basic first aid or any other medical things.
And we'll get into rescue in a little bit, but also my experience has been that these trekkers, so just to clarify, a seasonal trekker means people who get to the base camp and then go back from there. And then the climbers go at the base camp, they're at the base camp, but they're staying throughout most of the season trying to climb the mountain. And then they will stay at the base camp. These are your, bread and butter clients. They're staying there with you. You get to know them. So with the seasonal trekkers, what sometimes happens is they will get to the base camp because that's their goal, but they don't have the will to go down. So they will ask you to, as physicians in the Everest base camp, you are the physician certifying that this person has some kind of medical illness and they will not be able to trek down. So they kind of want you to write a statement for the insurance company to pay for their helicopter ride down from the base camp. Now, the problem with that is Everest base camp is already a very risky place. And when helicopters fly, we're already incurring a lot of risk. I mean, not to mention the cost of flying, and also the fact that there are a limited number of helicopters, and you want to save those helicopter trips for people who actually need them, for equipment, for really sick people, for bad accidents, and also save them for situations where weather permits these flights. But when there's potential for big payment from the insurance company, helicopter companies sometimes are willing to take additional risk, and they will fly these trekkers who really don't need to fly. They can get on horseback, or they can actually, most of the times, hike back down. So I have had requests from trekkers who had maybe an ankle sprain, or maybe they didn't really have an ankle sprain, but they asked me to write a statement saying that, okay, I need to go down on a helicopter because I cannot hike down anymore. So the kind of practical problems you see at Everest base camp. So let's talk about the kind of pathology that we actually see. But before that, I want to take a pause. And first of all, I want to ask Sachet if there are any questions, and also the rest of the audience or participants, if there are any questions that we can clarify this time before going forward.
Yeah, I have been monitoring questions. Anyone who has any questions, you can write in the chat and I'll try to answer those.
Okay, we do have a comment from Subhas. The summary is he thanks us for doing this, and he is going to have to sign off. But anyway, so we don't have any questions. Sachet, do you have any comments or questions so far?
I don't have as of now.
Okay. All right. So, oh, I see that Abhi is also here. Dr. Abhi, welcome and thanks for joining. I think it'll be interesting to hear what you have to say. We'll pull you in a moment. But Sanjeev, let's look at the statistics that we have from uh, over the years. The most important pathology seem to be the respiratory illnesses. And among them, like we didn't looks like we didn't categorize them in 2019, but among them, there's a lot of mention about Kumbu cough or high altitude cough. What is that, and how is that different from upper respiratory tract infections, and why are they so common in the Everest Base Camp or Everest region?
So Kumbu cough is this like dry cough that happens at Mount Everest, Everest Base Camp, and in the higher camps. They used to say that it's because of the cold weather, but this doesn't happen in Antarctica. So it's postulated that it is because of cold temperatures plus low pressure, hypobaric environments. So what it does is the cold temperatures make the air dry. So all the moisture in the air freezes. And also at the same time, when we breathe in cold air, the cilia or respiratory lining of our respiratory tract, they get paralyzed, so they cannot move to expectorate anything that our airway, like upper airway, produces. So that makes all the respiratory secretions a little bit thicker, and it's difficult to expectorate. So you keep coughing to try to push those things out, but you are not able to. So you just keep getting this like nagging, dry cough. You also cough. You can cough for like days in a row without getting better. And also there have been like incidents of people breaking their ribs just by coughing because they've been coughing so hard and so frequently. So this is a dry cough that happens in Everest Base Camp and in the camps above it, mostly from cold, dry air in low pressure environments that can break your ribs. So it's very important to recognize it. And this is different from viral illnesses because it's not caused by viruses. It doesn't cause fever. It doesn't cause any malaise, headache, or anything like that. But it's very notorious for disturbing your sleep.
And again, yeah, it's probably for a novice or like for a beginner in the high altitude areas, it's probably really confusing. Okay, is this should I be worried about HAPE? So what would you do when someone is coughing and coughing and coughing and just like couldn't sleep at all and feels unwell because of all this cough and hasn't been sleeping and probably has mild AMS from just having ascended? So what would you do? Would you to make sure it's not HAPE?
So initial stages of HAPE can also present as dry cough. So what we have ultrasound at the base camp. So we try to do an ultrasound of lungs and make sure that the ultrasound does not show any signs of B lines and signs of HAPE. If that's the case and they don't have fever and we rule out all these infectious causes of cough, we suggest people to do things that increases moisture in the air. So maybe like wear buffs while sleeping, wear masks while sleeping, or and also hydrate yourself really well, wear masks and buffs, maybe like do steaming if possible. And on top of that, if it's disturbing the sleep, we tend to give cough suppressants just for night. So something like dextromethorphan or in severe cases, codeine that suppresses the cough. And usually suppressing of the cough at night, hydration and wearing buff and try to increase moisture in your breathing air. It seems to help.
Yeah. So again, cough is a mystery. Even in lower altitudes, we don't really have a good treatment for cough, but we just try everything we can, right? So so over the years, we saw multiple different types of cases, but particularly most notable ones we want to know about are mountain or altitude related. So AMS, HACE, and HAPE. HACE and HAPE continue to remain not like so frequent, luckily, and then that's really good. We don't want them to be that frequent, but that's also because, like we discussed, these seasoned climbers, they know about these, and they know how to prevent this, and they are aware of the signs and symptoms, so they don't want to progress to haste and heap. Like some of the haste and heap we saw during our season was from climbers who were first-time climbers. They were almost equivalent to these seasonal trekkers. They were just going to climb these mountains because they could. They could afford the payment, and they wanted to go. And they hadn't trained well. They had no knowledge of how mountains are climbed. They had no knowledge of how much respect you have to give to all these rules and all these traditions, because all of them are rooted in science and they have a meaning, right? And then again, acute mountain sickness does continue to be very common. Looks like it peaked at 2019, but maybe that's just because we caught like most of them in the Everest ER. But I think it's still probably very common among the probably more common among the trekkers. But this is just a snapshot of the kind of high altitude issues that we see. It has been really nice to hear about frostbite from Subhash, who has done some work on frostbite. But we do see quite a few frostbites. So, but Sanjeeb, like, what did you do when you see frostbites in the Everest base camp? Like, it's not uncommon. Like, we see someone who took off their gloves at Camp 2 or 3 just to take a picture, and then ends up in our Everest ER with a frostbite that's setting in. So, what do you do when you see that in the Everest ER?
So we first make sure that there is no chance of refreezing that limb or that finger or that toe. If there is no chance of refreezing them, meaning if they're not going to the colder climate again, we put them in a warm water and try to thaw it by gently moving the water with some kind of stick or your finger, and changing the water until it thaws. At the same time, the ideal situation, on textbook, it says that we can use TPA, TNKs, or can use prostaglandin analogs, prostaglandin analogs are available at CWEC clinic in Kathmandu. So if someone has a limb-threatening frostbite, we ask them to go to CWEC clinic in Kathmandu and get the iloprost infusion done, and they have their own iloprost infusion protocols. At the base camp, we give them aspirin, if not like ibuprofen, which also acts as antiplatelet agents to prevent any clots in the distal capillaries, and just keep their first thaw their fingers or toes, and then dress it with aloe vera gel and keep it moist. Prevent it from getting dry and prevent it from getting frozen again, so that the function of finger comes back. Most of the times, if the bone is not involved, the fingers grow back.
So this is what
6 months or 6 months.
Yeah, and that's what's very different from getting acute dry gangrene, right, or even wet gangrene from limb ischemia, acute or chronic limb ischemia. So frostbite, because it's distal, like localized vasoconstriction, this will improve. But and for the most part, the idea is that the limb is still very vascular, and we have good regenerative potential. But again, if you have dry gangrene or wet gangrene from limb ischemia, like real limb ischemia, that probably won't grow back, and then you usually end up in amputation. So with frostbite, like you're saying, we're very conservative. We don't try to do much to grind. We don't try to say, oh, all the dead tissue needs to come out, which we would do if it was infection versus wet or dry wet gangrene easily, right? So that's also really wonderful. So I think the most important thing what I think we all need to remember is that yes, this is going to grow back, and we just have to be very conservative about it.
Yeah, and the other thing is, while asking them to go to specific hospitals in Kathmandu, tell them not to go to a surgeon. If they go to a surgeon, they will always try to amputate their fingers, which is not ideal in this situation, because this is not that dry gangrene. It grows back. So always send them to a place which has expertise of seeing high altitude related illnesses or frostbites. So that's one main thing. Don't send them to a surgeon. Surgeon will always ask them to like cut off their fingers, which is not the treatment.
Not evidence-based and not what they need, right? So yeah, don't send them to a plastic hand surgeon or orthopedic surgeon, which will invariably recommend amputations. So let's talk about helicopter rescues. We mentioned this briefly in the beginning, and we all know these have been a matter of controversy over the years. Let's leave the controversy aside, but let's talk about what, like, how often does it happen? What kind of scenarios would we do this in? And how like far high up can we rescue from? And does Everest ER have to coordinate most of it? So, most of the rescues from the base camp are coordinated by the Everest ER, mostly because, like we said earlier, Mr. Lakpa Serpa, who is one of our staff members, he's a high altitude rescue expert. There are many over the years, but he's one of the most experienced ones. And then he goes and rescues people from higher camps as well. I think we can go up to Camp 3, I think. Is that right, Sanjeev? That's
But I can go up to Camp 3 in a long line to get people down.
Yeah. So and if he feels the need, he will bring them down to the Everest ERs so they can be stabilized. Sometimes a lot of these people can be flown down directly. A lot of times, if it's a long line rescue mobile, I think to do a stopover at the Everest base camp helipad and then load them into the helicopter and then go down from there. But really depends. And these are the situations where you are coming out of your clinic and trying to see the patient outside the clinic, trying to maybe like carry some of your equipment and meet them at the helipad. But he will radio in, and then we can go and do that.
Yeah.
Some of these people will end up being rescued all the way down to Kathmandu. But there are situations where we end up in some of our hospitals in this area. And this is where I want to also have of you come in and talk about what how frequently he sees these people coming in, because I believe he's at the Namche Bazar Health Center. And also, Sanjeev, tell me, first, let's start with Sanjeev. Tell me about your experience with this over the 3 seasons that you were there at, and then we'll go to Abhiyu.
So the other reason that we coordinate, or not really coordinate, but certify that someone needs to go down on a helicopter is because most of the people, they have insurance that pays for it, health insurance or some kind of travel insurance that pays for it. And most of the insurance companies, international insurance companies, they trust our judgment, and we have good reputation that we will only certify people who needs to be rescued down to be rescued down. So that's why they ask their clients to go visit us, and that's why we give them a paper saying that, oh yeah, they have Kumbhakov, doesn't need to be rescued down on a helicopter, or they have like early signs of HIP or frostbite. We recommend that the patients go down in the lower altitude, go to Lukla or Kathmandu as soon as possible for further evaluation. And that's another reason we, like people at the base camp, they come to us for certifications or for a letter. About the rescuing, I think it's stayed like the same. The other thing that happened in 2022 was someone who was unconscious at Camp 2. That person was brought down Camp 2 from last night. So over the night, he could not be moved or rescued. So he was brought down in the morning at around 8. One of his pupils was blown. It's like 6 millimeters. The other one was 2 millimeters. GCS was like 3. So we started doing bag and mask ventilation, the only thing that we have, because we do not have ventilators. And one of us went down in a helicopter to one of the bigger centers, which has helipads in Kathmandu. And then later found out after the CT scan that they have a big subarachnoid hemorrhage. They did not make it, but that's something that can happen up at the base camp, not necessarily because of high altitude, but can be because of other things like comorbidities of hypertension or pre-existing aneurysms that no one ever knew. So we still don't know why that happened, but it seems like it's hypertensive emergency that happened up at the base camp, which is difficult to treat immediately if it happens at night or if it happens during bad weather.
Again, just to really reemphasize, yes, things that can happen at ground or like at sea level or even our altitude in Kathmandu, they can also happen at high altitude. All of these emergencies are still common. And also some of these illnesses seem to be more pronounced and more common when you get to high altitude. There are very few that are less common, but a lot of them are more common because our body is more stressed. So those three slides kind of like Sanjeev summed up what we discussed about. This is our last slide, just sharing some pictures of like I mean, of course, the work is stressful, rescue is stressful, you have to coordinate and things like that. But you also get to have a good time. At the Everest Base Camp, you get to hang out with a lot of people who have a lot of history, experience, and then there's a lot of culture there. There's a puja every time an expedition company starts their uphill climb, acclimatization climbs in the beginning of the season. You get to join some of them in their dances. We had two climbers in our that our expedition company was catering to. We're staying in our camp, and one of them had a birthday celebration there. So our Sherpa cooks are really wonderful. They can make, like I said, pizzas, but they can also make birthday cakes in the high altitude glacier as well. I got to hike with one of the teams during their acclimatization hikes all the way to Pumori. I believe it was just a acclimatization hike to Pumori. It wasn't even first camp, but I did go with them. And at the moment when I started, I thought it was wonderful. Maybe I will climb one of these mountains someday. But then as we got to that altitude, I started huffing and puffing. I was like, okay, this is it. I'm not, I can't do this. And then these airpods are wonderful and had a lot of respect for them. So Sanjay, you're saying something?
Pumari High Camp. I was saying it's Pumari High
Okay.
Camp.
Okay,
And
yeah. So that's
we might get cut. So I would like to request everyone who is interested in working at Everest ER, just volunteer to work at Gosaikunda first, and maybe volunteer to work at Feriche or Manang, and eventually you will get a chance to work at Everest Base Camp for sure. So if you have a will, there is a way, and I would like you to. It's a fun place. It's not for everyone, but it's a fun place to be, fun niche to work at. And like most of the people working in the area are like outgoing, fun, and specific kind of people. I think I dreamt about working at Everest Base Camp when I was in first year of med school. Worked at Mountain Medicine Society. I used to conduct that climbing for fun thing. We started biking for fun and everything. Then I was the chief editor of the newsletter for a couple of years, and get the chance, like by chance, to work at Everest ER in 2014 because I was just an intern, and there were like two of the other seniors who were supposed to work. One, Matidai, just got his appointment at the physiology, and then he could not go. So Sagardai was there, and he was working in Kunde, and he was supposed to go to a conference at the end of May, so he could not commit for the whole season. And that's how I was third in line, and I got a chance to work, and I went there and worked in 2014. Unfortunately, there was that that incident of icefall, which cut the season short. But like that's how I got chance. So if you are, I want you to work there. It's a fun place to be. So think about it, work towards it. By going to journal clubs, you will know about all these different altitude-related illnesses and everything. You have good people in Buddha Sir, Kamal Dai, Suman, and Subhas to guide you through it, even in the journal club. So, yeah, get help from their expertise when you can in person.
I see that Suraj Shrestha is also in this conversation. I believe he has also been to the Everest Base Camp, Everest ER. If our I don't know if we have limits to time. I don't know if we're gonna get stopped automatically in a moment. But any questions?
No, we have time. We
don't have
time
time.
for the meeting won't cut.
Okay.
We can continue the question and answer.
Yeah, let's do question answer for a little bit. While we're doing that, okay, so Abhi Gimari says, can we do an after session? For sure, we should. And then I would like to welcome Dr. Namse Bazar. So, Abhi, I want to pull you in and then can you comment on what your experience has been over there? I know you've been working there for so many years, and you see a lot of pathology, but it's different from having a seasonal base camp, a clinic, and then it's obviously at a lower altitude. But you get some of these people who climb down and they transit through your center. But then you also see people who get sick where you are. So can you share, like, touch upon briefly, like, I want to have time for other people as well, but maybe in a minute or so, can you summarize what your experience has been over the years? Are you talking?
Hello, can you hear me?
Yes.
Yeah, okay,
Yes.
thank you. Namaste, everyone. Dr. Savaru, Tashidile, Thangbu. And yeah, a little bit about myself. Thank you, Dr. Subarna, for bringing me in. I've been working in the Everest region for the last decade or so, since 2015. I'm primarily based at two stations, one in Namche Bazar and the other at Dingboche, which is at 4,400 meters. And for the last 6 expeditions since 2021, I've been doing Everest expedition, not at base camp, but higher up, Camp 2 and above, that's 6,500 meter, and multiple summits. And I stay there for a month or so. And we don't get as many patients as at base camp, but the patient distribution is probably comparable. I mean, the kind of ailments we see. This year we saw some 250 encounters, which is quite a bit. And as mentioned earlier, 2024 was the safest year reported so far, and 2026 has been even safer. So only 6 deaths reported earlier, and then one, as we all know, came back alive. So it turned into a missing persons case from a dead person's case, and highest summits so far. So yeah, that's a little bit about myself. And as per the cases, I was unable to join the first part of the presentation. I joined only as the frostbite section started. We do see that a lot. And one important point that Dr. Sanjeeb pointed out, that we should not unfreeze or thaw the limbs if there is chance of refreeze. That's the highest risk of for the gangrene to set in, or the frostbite to upgrade in its stages. So if there's chances of frostbite to get worse, to get frozen again, then at Camp 2 we don't thaw the extremities, because on the way down it'll get frozen again. And the more cycles of freezing and thawing there are, the grades go up like that. And also, we don't have iloprost. This year there was a pilot project where they could give iloprost at base camp, but previously it's not available, and up there at Camp 2, definitely not possible. Antiplatelets are used. Ibuprofen ibuprofen has found to be actually superior than aspirin in treating frostbites. Also, oxygen supplementation helps a lot, because there's a lot of, so during the thawing phase, there's a lot of release of chemicals, RS, prostaglandins, and whatnot. And if you give oxygen, the bad effects of those are reduced, and oxygen also helps produce heat in the body. Also, good nutrition, I would emphasize that a bit. Vitamins, especially like ACE, antioxidant effect. Again, there are oxidizing species that are released, which causes the most damage in frostbite. Some of them cancel them out, like vitamin A analogs are available in tablet form. Lycopene is one to mention. It's available in Kathmandu. and vitamin C. Vitamin E I haven't seen so far, but A and C are easily available. But the core of treatment for frostbite, as you mentioned, is keeping the body warm and not allowing the limbs to refreeze. So if there are chances to refreeze, we don't rewarm. So that's
Yeah.
a very important and maybe counterintuitive message I would want to add.
Yeah, thank you, Abhi. I'm going to pause you for 1 second. I just want to make sure that everyone else who has questions, they're answered. Again, Suraj, because he has been to the Everest ER, as what Dr. Suraj stressed, if you want to jump in and say a few words, I'd like to welcome you. But otherwise, if anyone else has questions, because I do want to make sure we make it as conversational and discussional as possible. So anyone else who has questions, and particularly Suraj, I would like you to come in.
Hi everyone. Can you hear me?
Yes, we can.
Okay. Just a quick, I just have a point to make for everyone, especially the young interns and those who have just graduated. You might feel like it's a big responsibility for you to go to Everest ER and then handle a lot of cases which you had not seen earlier, like while you were an intern or when you had been to Gosaikunda. But just to reassure you that you'll be receiving a lot of help from your seniors who are there, and you will slowly build your confidence in seeing the high altitude cases. So you just have to go on and trust in yourself and think that you can do it. And I think that's the main thing that we can do to build ourselves as a high altitude doctor, being there. And there will be a lot of Nepali climbers who will make your life easier. And as Dr. Sanjeeb had said previously, you will have a lot of fun working there. So it's not every day that you wake up at the base of Everest. Yeah,
Thank you, Suraj. Yeah, thank you so much. So again, I would like to say that I'm really glad that we could come together today, at least this platform where people who are interested in high altitude came together. And also really fruitful discussion, people who have had actual experience, including Sanjeeb, Suraj, and also Dr. Abhi Gimire, a different perspective, but really important insights. So again, I would like to invite and welcome questions. We can do a few more minutes, just out of respect for everyone's time. We will conclude in a bit, but I would still like to see if there's any questions, and I would like to encourage people to come in and say whatever you want to say on what did you feel about today's talk and what kind of feelings that they inspired in you. You can also always write into the back into the MMSN Google group as well, or just write to Sanjeev or to me or Suraj and even Suman, and about what you feel, what are you thinking. But again, also I really want to encourage everyone to come forward and talk right now. Just a comment from Suman. He says, as the helicopters are increasingly available there, is Everest ER at base camp getting bypassed and sick person getting to Ferisay or Lukla from higher camps more and more? So again, Suman, this is, I mean, maybe or maybe not, but again, we're just there to help, right? So it's not, the idea is not that we are at the center of everything and we want to control everything. As many services are available, I think that's good. If there are people who are working in parallel, I don't think it's bad. It's just good to have coordination, not to make sure that two helicopters don't go in and try to rescue the same person. That would be a waste of resources and putting some people at risk of harm. But again, there are if there are people who need help and who are getting help, that's okay. And again, obviously, if it is a genuine evac, maybe it's almost never happens. So Everest ER has this. It's not just a tent with medical equipment. We have a lot of radio equipment there, and like I said, usually Lakpadai is at the center of this rescue effort. Even when he's not directly contacted, he will jump in and get pulled in. So that's how Everest ER gets pulled in. We try to be the center of
communication. We try to be the coordinator. We don't have a central helicopter command that flies these helicopters. These are flown by private companies, and we try to be at the center of coordination. We do our best, but again, we're not saying that we want to control everything. We're saying that we want as much help as we can, and everyone who wants to help can help. But this is a good question, and it's a matter of ongoing debate and ongoing controversy, as far as my understanding is, and we're just trying to do our best.
Yeah, I think it is happening a little bit, but the numbers that we have shows otherwise. But as long as they're being seen by someone who knows high altitude, if they're flown down to Ferice or Lukla or even like Kathmandu to the hospitals where they have people who know about high altitude illnesses, that's a good thing.
So we saw these reports, international reports even that said, okay, there are so many fake rescues in Nepal, and we saw the clarification from Nepal police saying there are really not much evidences that the amount of fraud that is being reported, there is not real evidence that that's the extent of the fraud that's happening. But we all know at some level that there is fraud. There are people trying to make money out of vulnerable people, and there are scams and fake rescues. So obviously we don't know the extent of it, but there will always be these attempts, and we all have to be aware and be careful. But again, people who really need help should get help one way or the other. More questions? I would like to encourage people who haven't put in any comments or haven't said anything so far to come in and say something, if just to keep the conversation going, and we will just give 2 more minutes before we conclude, if that's okay with everyone.
I had one question.
Yes, that's it.
So what brings you to go back to Everest ER again and again? So what brings you every time?
Yeah, so Sanjeeb, maybe you want to answer that, but again, I'll just say one line. There's something about going there. It's a lot of suffering. You get sick. I had this bad cough for several weeks. I also had diarrhea, so it wasn't any different from a Westerner going to the base camp. I felt really sick for a few weeks really while I was in there. But at the end of the season, I said I do want to definitely come back. So I definitely still want to go back. There's something about the mountain, something about the experience, something about the community, but it's intangible at best. But Sanjeev, what made you go back?
So I would say the place is magical. You are surrounded by mountains on 3 sides: Everest, Lhotse, and Nuptse on the east, Pumari on the west, and there's, what's the name of the mountain that's directly on the north?
Chola is a pass. Chola Pass.
Chola Pass. And it's like surrounded by mountains, and towards the south the glacier flows. So the place itself is peaceful and magical. The other thing, once you go there for the first time, you make a lot of friends. And that friendship also pulls you there. It's a different kind of camaraderie and friendship. I still talk to a lot of people I met there in 2014. So yeah, it's the company and it's the place itself. And on top of that, if you've heard your seniors talk about HAPE, haze, frostbite for 6 years in med school, and you get to see those things there, it feels good. Also, you feel like you are getting to witness something that you've learned, and it's something different. So it feels like and also the other thing is, it feels like it is your niche within medicine after med school. Not many people have seen frostbites. Not many people have seen people with HAPE, haze. We've just heard about those things. But once you get to see them, along with making deeper friendships and being in such a magical place, it just draws you in again and again whenever you can. If that makes sense.
Yeah, we're all looking for purpose, right? So maybe we're somehow thinking that maybe this is our purpose. Abhi says, and he said he's been there for over a decade now, and he's just been expanding his work. He says, as if you find yourself asking why do people climb mountains, you're probably not ready to understand the answer. Maybe you're ready to understand it, but you probably just don't understand it deeply yet. So Just for the last minute, I want to bring everyone together and acknowledge the deaths that we recently had in Broad Peak. One of our celebrated climbers, and then many of the Sherpas that passed away in Broad Peak in Pakistan recently, including Nils Purza, who is a celebrated national celebrity at this point, and then also a really great climber and athlete. Let's take a moment together just to honor the legacy that he left behind, and also the legacy left behind by so many of our pioneer Sherpas and climbers, all the people who have established this history of Everest region and mountaineering over the decades. So I just want to really mention that we all respect them. We have respect and honor for these people who have done it. Just that reminds me, when I was there, I had just read Into Thin Air, Rob Hall's story about the disaster that happened in Everest in the early 90s. And I found myself trying to find people who were there during the disaster. And interestingly, our cook was also one of the cooks in their team. Sorry, John Crocker. Sorry, John Crocker wrote that book, and he was he witnessed a tragedy. So you get to meet people who have seen history over time. So that is really important too.
Yeah, John Krakauer.
John Krakauer, and I think Rob Hall was the main character of that story, right? So
one of the main characters. Yes.
Yeah, one of them. Yeah. Okay, so if we don't have any questions, I will just say that over the next 30 seconds or so, we're gonna conclude, and I will hand it back to Sachet for anything else he has to say before concluding the session.
So I think we have come to the end of sessions. I haven't seen any new questions. So thank you to all the participants for joining this meeting on the eve of the weekend. And thank you to Dr. Bhandari Dai, Dr. Adhikari Dai, Dr. Suman Acharya Dai, Abhi Gumire Dai for a valuable time. I believe many of the participants in here will have more motivation to work in Everest ER. And I believe we will see you and meet you in places where there is a good chance of beautiful hypoxia. That's it from my end, and I would like to thank MMSN for this wonderful opportunity. And I believe this interview will increase our motivation to work in higher altitudes and love the hypoxia even more. Thank you, and have a good weekend, everyone.
Sachet, you forgot to mention Suraj. Thank you, Suraj Resta, as well for joining.
And thank you, Suraj as well.
Thank
Bye
you,
bye. Have a
everyone.
good night.
All right, thank you so much.
See you on the 5th episode of Himali Sambad. Yeah, thank you.
Yes.
Thank you so much. Thank you for organizing. Good night.
See you on the 5th episode. Bye bye.